Enter a name, but you don't have to enter in your own name. Just put in your own code of your nickname or number, whatever it is. Or you can keep it anonymous, or if you want to enter your name, because you'll see your results as we go through this, okay? Keep it clean, thank you. Apparently it's being filmed. Here's our objectives. It's going to be interactive, obviously, as you can see. We'll go through specific cases, some complications of them, and the specific cases, the diagnostic and workup that you're going to be really doing in the ED. So here's the following question. Read it. A 5-year-old male presents to the ED with bilateral lower extremity pain for 1 month. Mom states he's been limping progressively. An x-ray is obtained and shown on the next slide. And you guys see an x-ray on your slide. Circle the abnormalities and click send, and you're actually going to see what people are putting in. You guys are kind of seeing, it's kind of good to know what you're putting. So, what is the most likely diagnosis? And you have a bunch, make sure you scroll down in your actual phone or iPad, because there should be 5 choices. So either leukemia, rickets, osteosarcoma, osteomyelitis, or Ewing sarcoma. So 95% of you have not answered. About 20-something percent, majority of people are saying osteosarcoma or leukemia. Yeah, it's kind of the top 2. All right, so I'm going to move on. What we were going for, and it's a similar picture, does anyone know what these are called? They're actually called metaphyseal bands or leukemic bands or leukemic lines. They're actually leukemia going across here and as well. It's basically the leukemic infiltration of the cells into the bone. Usually they occur in a transverse region and usually in the metastases and usually occurring in long bones. Of note, kids with leukemia, if they get x-rays when they present to you, 50% of these patients will have some leukemic bands or lines on their x-rays. Other things in your differential, you guys were kind of right. Rickets is up there. I kind of show a picture here. And osteomalacia, those are lines, they're called actually looser lines. I just want to throw this in so you guys can learn other stuff too as well. They look similar, they're linear lucencies, and they're usually perpendicular to the cortex. But again, rickets, that's not a typical presentation for rickets. They get more fraying and cupping of their bones, as well as, right here, rickety rosaries on x-rays, okay? So what we were going for was leukemia. Osteosarcoma presents a little bit differently than that. Usually, what does osteosarcoma present? What's a typical board question they tell you? Sunburst appearance, remember, on x-rays. This is bilateral, actual knee band movement. So leukemia, it's the most common childhood malignancy. Of all malignancies, it makes up around 29 to 39% of malignancies. We guys guys know this, it's immature white blood cells are invading the bone marrow. ALL is much more common. It's actually the most common. It's 5 times more common than AML. We don't really see CML or CLL in pediatric patients as much. There's about 2,500 to 3,000 cases of ALL diagnosed each year in the United States. So that makes it about like 3.4 per 100,000 patients. Peak incidence is usually 2 to 5, 3 to 5 years of age. And with our new chemotherapy, survival, 5-year survival is around 75 to 80%. How do they typically present? You kind of know this, but there's some weird ones I want to tell you. So they'll come in maybe with significant pallor, fatigue. We had that case before with lymphadenopathy. Yes, that can be lymphoma. It could also be leukemia as well. Feeling a spleen or a liver as well can be presenting symptoms. Bone pain is kind of a big one. Usually they come in with long bone pains. And again, what I told you is the infiltration of the leukemic cells into the periosteum. And that occurs around 21 to 38% of patients will complain of bone pain who have actually leukemia. Testicular swelling is another big one. Well, it's actually not a big one. It's very rare. But that has to be a differential for any kid that comes in with any type of testicular swelling. Leukemia can invade the testicle as well, and it can present like that. So keep that in the back of your mind. I know you guys are all worried about torsion, epididymitis, hydrocele, but keep in mind leukemia as well. Cranial nerve deficits, I'll go in a little bit more about that later, but if leukemia is already spreading into the brain, they can present like that. And mediastinal masses. Typically, you see T-cell leukemias coming in with maybe shortness of breath, and you end up thinking of mediastinal masses. So what do you do in the ED to diagnose this? If you're thinking the kid still has leukemia, you're going to get what? A CBC with a differential and a peripheral smear. Blasts, usually on the peripheral smear you might see blasts usually greater than 25%, kind of makes the diagnosis, but they can be creeping up. So if you're seeing blasts on a kid's peripheral smear, they need follow-up. Messing up more than one cell line, so they're cytopenic in more than one cell line. They might not have blasts, but you have to have them follow up with the hematologist, oncologist, because that can as well be leukemia. If you are thinking it's leukemia, you're pretty certain you have to get what you guys usually get in your adult patients, right? You're going to get your comprehensive, your uric acid to make sure there's no tumor lysis. You'll get your coag studies, because if they need blood, you might have to transfuse and get a blood type. You'll get your LFTs, possible mets to the liver, and check their LFTs. And usually we end up getting a chest x-ray to see if there's any mediastinal masses as well. That's kind of your baseline textbook, what you're supposed to do when a kid comes in and you're thinking they have leukemia. To truly diagnose it, how do we truly diagnose leukemia? Bone marrow, right? Other ways they can kind of present scarily, I'm not going to talk about it too much because I think Carla's talking about it later. It's tumor lysis syndrome, just briefly. Someone said people with hyperphosphatemia, hyperkalemia, and high uric acid. You're going to treat this with fluids, and I think Carla will go into a little bit more. We had a kid at downstate. It wasn't my patient, but I kind of heard about him because I was nosy. You have it? All right, fine. The hyperphosphatemia. All right, Carla will tell you about this. Okay? But that's also how they can present, and it does occur because it happened at downstate. And then CNS symptoms. Again, they can come in presenting with, they have leukemic infiltration into their brain. They can present with like headaches, seizures, although those are very less common, nerve palsies, and increased ICP. And those patients also check for hyperleukocytosis because they can present kind of similar as well. So let's try this one. A 7-year-old female with AML and is on chemotherapy presents to the emergency department with a fever. Her temp is 102, respiratory rate 24, heart rate of 120, blood pressure of 89/60, and she's satting at 100%. Okay, she's on chemo, she has AML. What would you like to do? And make sure you scroll down on your answer choices because there's, I think, 4 or 5 of them. And I'm trying to trick you on this. What's choice D? What is it, choice D? Peripherally and from inward? Okay. What's choice C? The majority of you guys are putting choice D, which is getting labs, a blood culture from the port and from the peripheral line. So this is the big controversy. So first off, what are we dealing with? We're dealing with a concern for possible neutropenic fever, right? A fever in a leukemic patient that possibly is neutropenic. What's the definition of neutropenia? It's an ANC less than 500, or an ANC that's going to be expected to drop less than 500 in the next 48 hours. So these kids get chemotherapy, usually in their induction phase, whatever phase they're in, and then usually around 10 days, 11 days, 12 days, they're going to drop and be their lowest, and where they'll be the neutropenic. So if they're kind of neutropenic in the borderline, they're on day 8, you got to worry that they might drop more. So that's neutropenia definition. In pediatric patients, there's anywhere, depending on what study you're looking at, 10 to 40% rate of documented infection. We know this gram-positive has become much more positive. A lot of people have ports now. So gram-positive is becoming much more positive compared to gram-negative and fungal. And then for the fever part of it, either the fever has to be greater than 101, or it has to be 100.4 for more than an hour, or 2 times of 100.4 in the past 12-hour period. And remember, in all these oncologic neutropenic patients on chemotherapy, you're not supposed to be getting rectal temperatures. These are all temperatures taken orally. Why don't we want a rectal temperature? Yeah, possible, damage of the mucous membrane and risk from infection. So oral temperature in all these patients. So here's the answer, and it's not a true answer. So basically, your ED management, you're going to do a good history and physical. In a well-appearing, in a sick kid, it's kind of easier, right? A sick kid, they're going to get full coverage, be admitted, and right to the ICU or wherever, monitored bed. The labs you generally want, or just really need, if they're not that sick, is a CBC, and make sure you get an ANC and a blood culture. Now here's the problem. Here it is. The big debate. You have ISDA guidelines came out in 2010. They recommend on any adult or pediatric patient that comes in and they have fever with neutropenia, they have to get cultures from their port and peripherally. And the port, you have to ask what type of port it is, if it's double lumen, triple lumen, because you're technically supposed to get cultures from every single lumen. So if it's triple lumen, there should be 3 cultures from the port. Double lumen, 2 cultures. And they recommend peripherally. And it kind of makes sense. They have some studies they looked at, and they're like 7 studies looked at this, and I think it was a rate of, when they looked at just from the port and from peripherally, they were able to get a positive culture in peripherally 13% of the time, and nothing from the port. So that's why they said you should really get from the port and peripherally. But in pediatric patients, and in talking to our oncologists in some studies, they have a port because they're little. I mean, because they need chemotherapy, but also they're little. They're going to be getting lots of sticks and lots of blood. And you don't, a little baby or a little 2-year-old, it's hard to get blood from in general. Now you're sticking them, and it's traumatic. And when we're speaking to our oncologists, we don't have, let's say, per se, neutropenic fever guidelines and what you're supposed to do. A lot of hospitals have that, like CHOP has that, Emory has that, where when they come in, here's what you do, where you get the blood from. We don't have it. And speaking with our oncologists, they're comfortable if the kid's a little bit young and they're pretty well appearing. You can probably just get it just from the port and don't necessarily have to stick them peripherally. It's hospital dependent. I don't know where you guys will end up working later in your life, but and where I trained, we did from port and actually peripherally all the time if they came in for fever. Again, it's case by case, hospital dependent. There's some, I put up this is, you can't really see it well. There's lots of risks, because in other hospitals, we wouldn't really do this here, but just so you guys know, if it's a well-appearing kid, and they're followed with oncology, and the oncology is like really on board, the parents are really responsible, if they have low risks, meaning they never had sepsis before, depending on which criteria you use, their labs aren't really abnormal, they don't have Burkitt's lymphoma or AML, just plain old ALL. If they're kind of semi-well appearing, you can usually just give them a dose of antibiotics and then have a follow-up the next day and send them home. In talking to our oncologists here, we don't really will recommend that because patient population and the kids, the follow-up is not as great. So we would probably just admit those kids. But keep in mind, if you're in another hospital and they're sending kids home like that with low risk, don't be too surprised. What's your antibiotic usually, and what we're doing here is cefepime initially. And if their ANC is low, we are considering admission with IV Gen. I talked about potentially discharging. For high risk, you can try cefepime, Vanco, and Gen, and you're admitting them. I think this is kind of similar in adult patients as well. All right. Same 7-year-old that we just talked about had chemotherapy 2 weeks ago. She has fever, abdominal pain, and vomiting. Here are her pertinent labs. She has a white count of 0.1 with an ANC of 100. Her hemoglobin's 9. Her platelets are 200,000. Her AST is 120. ALT is 150, and her total Billy is 3.0. Circle the abnormalities. We decide to get an X-ray. Her belly is tender, so we decide to get an X-ray. You guys see the X-ray? And circle the abnormality. Circling that normality. All right, so what is this? Anyone know what this is called? Do you see air within the wall of the intestine? Pneumotosis intestinalis. Usually you see this, what we see most, oh my God, I didn't even realize the name. Alright, so pneumotosis intestinalis. Usually, when do we see pneumotosis intestinalis? Neck, right? Usually neck. What do you guys think we're dealing with here? Anyone know? It's not a multiple choice. Yes. So if I showed you the end of scanning this kid, and what's that? It's bowel. Inflamed cecum, right? It's pretty inflamed, pretty bad. It's actually typhlitis. I don't know if you're going to talk about it. I did talk about it a little bit.
No, I'm not.
All right. It comes from the Greek word typhon, meaning cecum. Things you have to know. So basically, I've actually only seen this one time, and I saw it at County, and she was like 30 years old with breast cancer. And she came in with fever, she came in with abdominal pain, and diarrhea. And then when I was checking her exam, she had like diffuse abdominal tenderness, but when we pushed on her right side, she was like jumping really bad. I got really nervous, and I don't really know adults that well. But we ended up scanning her and giving her antibiotics, and she had the same exact scan as that. And she had typhlitis. Basically what it is, usually patients, when they go undergo chemo, they drop their white counts, right? The whole point of chemo is to kill off any type of bad cancer cells. They don't really know what truly causes this, but having them being very neutropenic, and then somehow they think the bacteria ends up invading kind of your intestines, and kind of just causing inflammation, kind of just infection in the actual intestines. Usually it's in the cecum. The triad that they talk about is abdominal pain, fever, and diarrhea. It actually has a high mortality all across the board. Pediatric patients and adults, 20%. There was some pediatric study that looked at like 42 patients in the past, I think, 5 years, and what was their rate of dying or morbidity, and actually they all survived, so maybe we're just a little bit more on top of it, I don't know. But usually the treatment is pretty standard treatment. You're going to give broad spectrum antibiotics, IV fluids, keep the patient MPO. Sometimes there'll be small bowel obstructions associated with this, so you might have an NG tube and decompress the bowel as well. And typically they don't go to surgery, okay, at first. Usually a lot of times they try antibiotics for this first. Only times they're really going to have to go to surgery if there's a perf already and there's air in the stomach. If they're significantly bleeding and you can't really stop the bleeding, although you probably corrected their labs, then they will have to go to surgery. Or if they're just clinically deteriorating after getting IV antibiotics, then they go to surgery. But the majority of the times, you don't go to surgery right away. And then when it comes to kids and scanning them and reading lots of papers and stuff, they don't really say what you have to do. Usually you start with an X-ray and make sure there's no free air in their belly, and see if you can see any signs like this, and start them on antibiotics. And then you speak with hematology oncology, you speak with surgery, and see if they actually need the CAT scan. I feel like the majority of the time they are going to want the CAT scan on this patient. But our book says, and lots of other things are saying, that you can do serial abdominal x-rays just to keep monitoring the patient. Fasciitis. Other things, I try to throw you off. So in that question stem, there was elevated LFTs and elevated Billy. Does anyone know why? I don't know if you guys remember. Chemotherapy drugs just kind of do that to you a lot, so don't be too concerned about when you see a little bit of a bump in LFTs, a little bump in the bilirubin. Usually that's from chemo. I'm going to talk, though, about nausea and vomiting and mucositis, because this is very common. You'll see this with your leukemic patients that are coming in, they get sent to the emergency department. So just a little bit on pediatric and what happens with kids. So they have different phases for leukemia, right? Treatment. Usually they have an induction phase, and you don't really need to know this truly, but majority of leukemic patients in their induction phase, they end up getting steroids, vincristine, and asparaginase, and that lasts for 4 to 6 weeks. And that's supposed to kill off any leukemic cells. And then they'll do a bone marrow to see if there's any leukemic cells left, and hopefully there aren't. And then they'll start them on the consolidation phase, which lasts about 4 to 8 months. And they get other medications like methotrexate, doxorubicin, cyclophosphamide, and etoposide. Unfortunately, after that, then they'll be on a maintenance phase where they get like different doses of chemotherapies for the next total of like 36 to 42 months. So they're getting chemotherapy for like 3 years. Unfortunately, a lot of these agents, and it depends on which agent or what type of emetic risk they have, make you want to vomit and throw up. And little kids don't do well with that. Adults don't do well with that either, but little kids especially do not, and they get dehydrated very easily. If you look at their certain charts, they'll show you like, let's say vincristine has a 1 on a scale of 1 to 5 causing nausea and vomiting. Vincristine's low, it has a 1. But asparaginase is a 1 as well, but you put them together, that gives you a 2, and you have a little bit more of a risk for nausea and vomiting. So if they do get sent to you, oncology is probably going to talk to you, and I just wanted to throw this out there so you guys are aware of this, because I didn't really know when I was working you can use these medications. First off, they're going to use very high Zofran doses. It's not your typical like 2 and 4 milligrams. They'll be like using 8 milligrams, pretty high doses, even for like little babies. You can look in your Harriet Lane and you'll see the high doses they'll use. They'll also try like dexamethasone. They'll give like Ativan to help stop their vomiting. And of course, you're probably going to have to keep these kids on fluids. And then hopefully they'll just get better. And this is pretty common. I've seen a bunch of these patients. I remember when I was in pediatric residency because we had an onc service there. The other thing I saw a lot in residency was mucositis. You probably see this in adults as well, right? In your GI tract, it's pretty rapidly turnover of cells, right? Your tongue, everything, it's rapidly turnover, and that's what chemotherapy agents go for. They go for rapidly turning over cells, so they kind of just destroy the barrier of the mucosa throughout the whole entire GI tract, not just your mouth, but it can even go down to the esophagus and the GI area. And again, that's very uncomfortable for little kids. It affects 35 to 40% of pediatric patients receiving chemotherapy. There's not much of a workup. Technically, if they get sent to you, there's not much of a workup that you have to do. You can check blood, make sure they're not slipping freely, bleeding. Sometimes they'll have like be bleeding a lot in their mouth as well. But the management is usually they'll give like topical. You guys heard of what's it called? Triple magic mouthwash. Sorry, magic mouthwash, which is like the diphenhydramine, lidocaine, and Maalox. They even try. I don't know how to say it. Sucrobate, and that's for GI irritation as well. And they'll put those kids on that, and then majority of the time, by the time they're getting to you, you're going to be giving these kids morphine to help them try to drink and giving them IV fluids. That's kind of the management for that. All right, so moving on from leukemia, let's move on to Wilms. A 2-year-old female has recently been diagnosed with a Wilms tumor. Her presenting signs and symptoms likely included, and you have, I think, 4 answer choices. we're going abdominal mass, hematuria, and I can't expand it for some reason. What's the last part that they have? Abdominal mass, hematuria, and what? Hypertension and fever. 31% no answer. What was my answer?
Jack, I think that station with that state changes.
Were you there for that one? I was talking about it, yeah. The lumps and so majority put the right answer, abdominal mass, hematuria, hypertension, and fever. So we're going for Wilms tumor. And like Andrew was saying, I was going to say it. So I've seen it here. Like I've seen kids being treated for Wilms tumor, but never actually coming into the ED. When I was a resident, I never saw that. But literally, there was I think she was like 5 years old, 6 years old. She came in. Her chief complaint was lumps in her stomach. And we're like, it was very slow and downstate, so we're just sitting there. We're like, let's go run over and look, you know? And everyone's like, oh, it can be like a rash, whatever, blah, blah. And then we pick up her shirt, and you just literally see the tumor sticking out of her. Like, we didn't have to push on her belly. You could just see the tumor sticking out of her. And the patient hadn't seen a pediatrician. No, actually, she was like 3 years old. I'm sorry. She hadn't seen a pediatrician for a while for some reason. And she had no other symptoms, just the lumps in her stomach. It was huge. It probably had been there for months, and we just didn't notice. The triad of your Wilms tumor is abdominal pain, hematuria, and hypertension. Things I want to tell you about though, Wilms tumor usually like median age is around 2 to 3 is when they'll present. And usually majority of them are under 5. After 5 is like less than 10% chance you're getting a Wilms tumor. Abdominal pain occurs in like 30 to 40% of patients. Hematuria 12 to 25%, and the hypertension 25% of patients. They can also present, and I mean I've never seen it or heard about it like in any of the cases I've listened to, but because these are in the kidney, right? The tumor is actually in the kidney, and it can present with the blood in the renal capsule area, and then it can just bleed out. If you end up touching it or bangs it, it can bleed out, and it can present hemorrhagic shock. That's another way, so just keep that in mind. On the physical exam, once you start thinking that the kid has a Wilms tumor, don't let people start poking her belly so much, although I think we were doing that day, but don't let people poke her belly because, again, for that risk of possible hemorrhage. They'll even have signs, like, and I remember as a pediatric residency, a kid with Wilms tumor on the actual room, please do not examine abdomen, because it's already diagnosed, you need to touch it, okay? Usually, the Wilms tumor doesn't cross midline. It's usually be one side. Hers was on her left front row that we have. So what do you want to do for this patient? So what did me and Andrew do for this patient, basically? The kid came in with bumps in their stomach. You think it's a mass. What do you want to do? It's free text. You could free text the answer in. What's your first test or imaging study? Basically, we're between CT and sono. Okay, so here's your workup. First off, when the kid comes in, make sure you look at the vital signs, okay? If they're hypertensive, you have to speak to oncology and renal to decide what you're going to do for that. Laboratory-wise, you get your basic cancer workup, that's including your urine, and you want to make sure, check their creatinine, make sure their creatinine is normal as well. Get coag and LFT. So ultrasound is the first test, and probably the only test you're probably going to do in the ED. We did the ultrasound, we did bedside one, and then we sent it for it, and even in their reading for the girl, they said that looks like it's Wilms tumor. And then we admitted that patient because, speaking to you, they were considering MRI. You can do either a CT or an MRI, but the problem is it has to be protocolized. So you need to speak with the oncologist before they do this. Sometimes you need sedation, so it's better off you probably would just admit the patient and let them all discuss exactly what they want to do for this. Once you get your ultrasound, you're good. It's probably going to say it's a Wilms tumor, and let them further evaluate. And eventually, the patient's going to get it removed, the cancer removed, and figured out. Just so you guys know this, because like I kind of knew this when I was talking to that mom with the patient, but it's kind of good to know, like prognosis and things. You don't want to talk too much about it, but for your own like knowledge, and when you see a kid, you might never see them again. You kind of want to know if it's a bad cancer or not a bad cancer. Things that they say it's a bad cancer, you know, they're going to do the biopsy or whatever, they're going to take the tumor out, they look at the histology. If there's anaplasia on it, it's poor prognosis, like 40%, 30% survival. Tumor stage. Don't really have to memorize staging, but just know that if it starts spreading more, if it starts going to lymph nodes, starts invading the inferior vena cava, it's worse. There's molecular and genetic markers you can look for this. And then if the kid's older than 2, it's a worse prognosis. That's just general background information. But overall, Wilms tumor is a pretty, depending on where you read, 5-year survival is around 90%. In the US, what they end up doing here is they actually take the cancer out, the tumor out, and then they start chemotherapy. In Europe, they do it vice versa. They start chemotherapy, and then they take the tumor out. So our girl, we ended up taking the tumor out, I think, the next day. They scanned her, and then they took her to the OR and took it out. She ended up not having Wilms. Well, she had kind of like a subset of Wilms called clear cell adenocarcinoma, which had a worse prognosis, unfavorable histology. But she is doing well, because I ran into her sister at county mention, so and she's doing well. All right, this is the last section of things. So a 3-year-old male presents with abnormal eye shape. On exam, you know he has meiosis and ptosis. Exam is otherwise normal. I can't read the rest. I think it was the first study we want to obtain. And there's a bunch of choices. Chest x-ray, neck CT, head CT, abdominal ultrasound, or urine cups. I think chest x-rays most of them. And the second is head CT and neck CT tied. What are we dealing with here, Ethan? So I was going for Horner syndrome. So Horner syndrome, right, you get the meiosis, ptosis, and then hydrosis. An exam when looking at the patient. So this was a patient in my residency, how they came to the ED. He was a teenage guy, and he came in with this complaint, his eye looks weird. And looking back on it, they ended up scanning his head, and his head was fine, and they had to follow up with neurology. Probably wasn't the best workup, because the scan was normal, and the neurologist was like, what are you doing? And then they ended up getting a chest x-ray, and then getting further workup, and he ended up having a lymphoma that was probably pressing on his ganglion cells and then causing Horner syndrome. So usually your first test that you want to do, at least invasive, is chest x-ray. And why I'm telling you that is, in kids, it's different than adults. If a kid comes in with Horner syndrome, the #1 cause, like in all age group, is cancer, some type of malignancy, and the most common being neuroblastoma. So you have to this kid has to be worked up. And in our population, I'd probably not send this kid home. They'll probably end up getting, and if you read lots of literature, they end up getting a head, neck, and a chest CT eventually as well. And maybe even abdominal sonogram as well. But the first test you want to do is a chest x-ray. It's the least invasive. On your boards, always pick the least invasive things, you know. To see, because it could kind of guide where you're going to go from there. And just to throw out there, besides neuroblastoma, rhabdomyosarcoma can cause it. There can be brainstem malformations as well. And infants, if an infant comes in with Horner syndrome, it's pretty much a given that this kid will get neuroblastoma. Okay? So if a baby's coming in and they have Horner syndrome, don't let that kid leave. And there's some studies showing that, like, even if you end up evaluating a kid, scanning a kid, whatever you end up doing, let's say that day, and nothing comes up, a few months later, they keep following them, and then they'll just get the neuroblastoma, and there was nothing picked up on the imaging when they first came in. So Horner syndrome, be scared of Horner syndrome. So now I'm going to talk about neuroblastoma. So you guys kind of know this. It's derived from the neurocrest cells, and it goes in the peripheral sympathetic system, in the peripheral sympathetic chain, adrenal glands, all the way up your chain of your actual chest, and even through your neck. And it secretes these hormones. Your clinical presentation, typical presentation though, that we've seen, and I remember seeing in residency as well, is the same kind of Wilms tumor. Like, it mom's giving the baby a bath, and usually it's a little younger age than moms, usually around like a year to 2 years, and they feel like a mass in the stomach. They can come in with like fever and systemic symptoms as well. I talked about the Horner syndrome. The periorbital ecchymosis, that occurs once the actual neuroblastoma has invaded the orbital region in the brain. Scoliosis, if the neuroblastoma is kind of affecting their spine, and unfortunately, I saw that too. A kid had neurofibromatosis, and she came in for scoliosis, and they did a MRI, and she had a neuroblastoma. And secretory diarrhea. If the this is very rare, but just so you guys know it, if they have VIP, it secretes that hormone, it'll lead to secretory diarrhea. All right, so here's a video. Let me see if it works here. Okay. So. You guys kind of get the point, right? She's so cute, yeah. What is that called? What's the diagnosis of that? No one's answered. Question. Thank you, Tabby.
Can we go back and watch it again?
Yeah. All right, see if anyone else. So, okay. Anyone answer? 20 Oh, I have some. K2? Good, you guys got it. So where I was going for oxyclonus, myoclonus, and if she was walking, she'd probably be ataxic. If you ever see this, typically, and how they'll describe it on your boards, and how you saw in the video, they have these rapid dancing eye movements, rhythmic myoclonic jerks involved in the limbs or even the trunk, and they'll be ataxic. She wasn't walking through, so you can really see. If you see a patient like this, they cannot go home. They have to be looked up for 50% of children will have neuroblastoma or probably develop it at some point. I don't know why I wrote 1 to 3%. That's wrong there. I don't know. Other causes, though, you have to think in your differential. Infections can be in there, and then toxins as well. I didn't see K2 on the differential for that, but phenytoin, lithium, toluene, gallium. But really, this is typical how they present. So back to neuroblastoma. Same idea. Ultrasound is going to be your study in the ED. And then do not do anything further. You're going to speak with oncology because they're protocolized, whether you're going to get CAT scan or MRI. And it's the same exact management. The majority of them, they end up resecting them, followed by chemotherapy, and they use a lot of radiation for these patients. For your own knowledge of how these kids do, and there's a staging system of where it is. Obviously, the higher stages are worse. I just wanted to mention stage 4S. This occurs just really, it's in infants, less than 1 year of age. It's disseminated disease. It'll be like, they'll have a mass or something, and then it'll be into their skin, into their bone. But luckily, 85% of these babies survive. A lot of them with no treatment at all. It just actually gets better on its own. That stage 4S, you just keep that in mind. For low-risk tumors, meaning not too bad, they'll just do the surgery, and they have survival rates of 85 to 100%. For high-risk disease, meaning spread more, they have a 40% 5-year survival rate. So here's conclusions. I'm done. So we talked about leukemia and its complications. Let me just quiz you really fast to make sure you learned something. Give me one weird clinical presentation of leukemia. What do you think? Okay, fine. That's fine. Okay, next week. But symptom, they come up with something. A weird one. All right, so I want you to testicular swelling. Keep that in the back of your mind. What about, what are you going to do for the workup for Wilms and neuroblastoma? Okay, good. Horner syndrome.
Bad.